Hi, everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I am your host, Kimani Hendricks, Multimedia Communications Coordinator for MS Focus, and I'm joined by Adnan Subei, who will cover COVID-19 and MS updates. After a presentation, we will allow time for questions and comments. Now, I'm delighted to introduce our speaker. Adnan M. Subei, DO, a board-certified neurologist, earned his doctorate in osteopathic medicine in 2008 at Lake Erie College of Osteopathic Medicine in Pennsylvania. He completed a fellowship in neurovisual disorders at Michigan State University Department of Neurology and Ophthalmology in 2009. He also did clinical research in MS at the University of Texas Southwestern Medical Center in Dallas until 2010. He then returned to Michigan to complete his internship and neurology residency at Michigan State University, Sparrow Health Systems in 2014. During his senior year, he served as resident education liaison. Upon completion of his residency, he moved to Ohio for a neuroimmunology fellowship with an emphasis on neuro-ophthalmology at the Cleveland Clinic Mellon Center for MS Treatment and Research. His fellowship was sponsored by the Clinical Care Physician Scholarship granted by the National MS Society. Dr. Subei joined the Memorial Neuroscience Institute and Memorial Physician Group in the Division of Neurology in 2015. He is the medical director for the MS program, as well as the program director for neurology residency. We're pleased to have him join us to present this important topic. Dr. Subei, thank you for being with us today, and I'll turn it over to you.
Thank you for inviting me to give this talk. And this is actually a great thing that you're offering for patients, is through the web, and I'm glad we're able to do this and provide some education for our patients. And so when they asked me to present, I was thinking about what topic would be interesting, and obviously everyone's has COVID-19 on their mind. And especially with us, being in the field of MS, trying to think about how does COVID-19 impact MS. So the talk, what I'm trying to do is give an overview about COVID-19, what we know so far about the disease, and then the second half would be its relationship to multiple sclerosis. So I don't have a slide about this, but I'm just going to start with saying, but I have no disclosures related to my presentation. All right, let's see. Okay, so COVID-19, we all know, is a global pandemic, something that no one has ever gone through for 100 years or so. And right now in the US, this is data as of today, there's about 16 million in the world with COVID-19, of which 4 million plus in the United States. The death rate, we've reached about 660,000 worldwide and 150,000 in the US. And so to sort of just put that in perspective, Tallahassee's population is about 190. And so we've wiped out almost just Tallahassee, just counting the deaths that happened in the United States, unfortunately. So COVID-19 is a pneumonia. It's a virus that affects the lungs. And the way that this happens is that the highly contagious virus would enter our body and system through the nasopharyngeal airway, so through the nose and the mouth. And the virus would go down the lungs into the alveoli. So these are the smallest pockets in the lungs where air exchange happens. And they cause an inflammatory reaction. There's an immune reaction that happens in this area where then you have T cells and B cells causing all sorts of destructions within the alveoli. So the end result is that you have damaged lung that's unable to get oxygen from the blood, from the air into the bloodstream. And so then the patient's oxygenation level goes down, and that's essentially what affects them. And what I'm showing here on the left-hand side is a CAT scan of the chest in a patient with COVID-19, and the all the black area that you see here is lung, and then you can see the damage, this whitish area within the lung itself. And so that's all damaged lung. That's fibrosed and deemed unusable. And that's what the yellow arrows are pointing at. So yes, it is a virus that it starts with, but then it causes an immune response, which is how it affects the patient. So what are the symptoms of COVID-19? And so it would be fever, chills, cough, shortness of breath, difficulty breathing, fatigue, muscle or body aches, headache, new loss of taste or smell, sore throat, congestion, nausea, vomiting, and diarrhea. So these are your typical viral symptoms that we even tend to see in patients who have the flu. Perhaps not as much emphasis on the loss of taste or smell. And then the degree of severity is not the same. So if you look at the box showing the emergency symptoms, and so trouble breathing, persistent pain or pressure in the chest, or confusion that the patient may develop, inability to stay awake or wake up, or bluish lips or face, that prompts an immediate need for a 911 call and to be taken to the emergency department for care. So how do we diagnose someone with COVID-19? It typically is a nasopharyngeal swab to test for the actual virus, the RNA of the virus. So as you can see here in the picture, you put the swab all the way in through the nose, and it goes to the back of the throat. And you leave it in there for 10 seconds, and sometimes they'll twist the probe so that you can collect enough of the sputum that's in there. And then you take it and send it to the lab and look for the virus. The antibody test is not a good test. Antibodies are developed by the body in response to a virus or some kind of a pathogen. The problem with the antibody test is that if someone has a mild case, then you may not mount enough of a response. So the antibody test may be negative in someone who has had COVID-19. The other issue is that it doesn't necessarily mean that someone is protected from the virus if they developed antibodies, because yes, someone may have developed antibodies, but they're still not strong enough of an immune reaction to prevent another infection, especially if the virus mutates and it changes in its characteristic. And the other issue is that the antibodies may go down with time and deplete. So someone who's positive, you can retest the antibodies and then they're negative because they lost the immune response. So typically we just don't rely on the antibody tests at all. The typical disease course goes for about days to weeks. So you have an incubation period where it's about 5 days or so before someone starts to develop symptoms. So let's just say hypothetically, if just this second right now, I start to notice that I'm having a fever and body aches, that means that probably 5 days ago is when I got the virus, which means that anytime during those 5 days, whoever I interacted with, I probably transmitted the virus over, and I didn't realize that I had the symptoms. Once the symptoms develop, then it's about 5 to 10 days of a mild case where you get all these symptoms that I described, but in a mild form. And then after that is when, if the person were to have a severe case of COVID-19, then they develop symptoms. And that's the dyspnea, which basically means difficulty breathing, tachypnea, rapid breathing, or hypoxemia, where there's not enough oxygen in their blood. The mild symptoms meaning just basically fever, cough, body aches, fatigue, and nausea or so, and diarrhea. So, but when it starts to affect breathing and oxygenation, that's when you know that we're heading in the severe category. And so then that's what we call ARDS, which is the acute respiratory distress syndrome. And so then the lungs go into full distress and there's inflammation in the lungs that's just preventing proper oxygenation. And then patients recover, then they transition into that recovery phase afterwards. And obviously the severity of the disease and what the patient's course would be, there is a relationship between the viral load and the severity of the disease. So if someone just gets a little bit of the virus, then they're probably going to have a mild case. If someone gets a heavy dose of the virus, then they're probably going to have a more severe case. And then the person's own immune response to the virus. So if they have a strong immune system, then perhaps they can fight a mild viral load and maybe even a moderate or severe viral load. But if someone's immune system is not as good, then their ability to fight the virus will not be as strong. So what are the risk factors for the virus? So we know that age, so greater than 60, hypertension, diabetes, obesity, heart disease, chronic kidney disease, COPD, and then those that have immune compromised state, for example, those who get chemotherapies for cancers and other diseases, and then sickle cell disease. So those are your typical risk factors. Now, the treatment of COVID-19 has changed over the past few months as we've learned more and more about the virus itself. So there's what we call symptomatic treatment. So what we can do to try to help patients get through the course of the virus. And that's the first thing to do is to give them high flow oxygen, to give them lots of oxygen through a nasal cannula. And then we can change the settings to maybe a BiPAP, which is a machine that forces air into the lungs. And then maybe we can give them inhalers to open up their airways, and then proning patients, so laying patients on their belly so that they can use other parts of the lungs that can get better blood flow and oxygenation, or using a machine called ECMO, which is like an artificial lung. So then that would do the breathing for the patients, and that's in the most severe cases. We have immune-mediated therapies because COVID-19 causes a lot of inflammation in the lungs. And so part of the treatment would be is to address the inflammation itself. We tried hydroxychloroquine, and in 3 large studies, it really didn't give us the answers that we wanted in terms of decreasing the rate of severity and shortening the disease duration. So that didn't really help us. Tocilizumab is an immune therapy, and it fights one of the immune markers, IL-6, and so that tends to help in some patients if they have a high IL-6 level. And then dexamethasone, which is basically steroids, so that also decreases inflammation. You may be familiar with some of these medications: interferon, which is used in multiple sclerosis, fingolimod, which is the brand Gilenya, and eculizumab, which is the brand Soliris. Eculizumab is used in patients with NMO, neuromyelitis optica. So all 3 of those medications have also been tried or are in trial for COVID-19. The interferon form that they're trying in research is an inhaled form. The fingolimod is still in a clinical trial. And then eculizumab, they've talked about it and they designed a study, but then I don't think anything has moved forward since April. So I'm not so sure if they're still doing that. But basically they're trying immune drugs to see if they could fight off COVID-19 because it's an immune disease in the lungs. Now, antiviral therapy, so we have remdesivir, which is the only FDA-approved medication for the virus, and it decreases the replication of the virus in the body. And then convalescent plasma is basically plasma that's taken from patients that have recovered from COVID-19 and they've developed an immune response. So then you take this plasma and then you give it to people that are still fighting the disease so that that immune response that's in the plasma could help fight off for the other person. So one good thing would be is to spread the word that any patient that you know that has recovered from COVID-19, it would be really great if they could donate plasma so we can give it to as many people as possible. Now, in terms of the epidemiology and how it's impacting Florida, I know some of you may not be in Florida, but I'm in Broward County, Hollywood, Florida, southern part of the state. And so COVID-19, as you know, has made a big impact on our state. So what I'm showing you here is 2 graphs. The one on the left-hand side shows the number of cases. And we thought that back in April was our big surge in cases. And you can see all these dotted red lines are when the state decided to close down. And you can see how, okay, things got better and the curve started to go down. And then these green and blue bars are when we started opening things up. And now you can see this huge surge, which is nowhere, close to what it was back in April. And despite this, there's not really been much closure other than this line, which is the closure of bars, and that's pretty much it. So you could see we're at a big height here right now at this time. In terms of deaths, so the same thing. So the deaths always tend to follow by a few weeks. So you can see the death rate here peaking, and then it improved, and then now it's going back up. And so, certainly these are some of our worst times for Florida. So if Florida was its own country, and so we would be the number 6 worldwide. So we have right now about 450,000 cases in the world. And, number 1 is the US, number 2 is Brazil, 3 is India, 4 Russia, and then we're sort of fighting with South Africa. We're trying to beat them for the number 5 spot. But so this just gives you a perspective about how severe COVID-19 is in Florida. And within Florida itself, mostly in South Florida. So then you have people who sort of question, is the virus really getting weaker because it's just not as many people are going into the hospital and it's milder now, maybe we don't need to take it as serious? Well, so let me give you this perspective. If in April, and these are all rounded just so I can make it easier of a point to make. So if in April we had about 30,000 cases and there were 1,000 deaths, so the death rate then would be 3.3%, right? Now, in July, we have 400,000 cases, but then 6,000 deaths. So the death rate went down to 1.5. Aha, so okay, so you're saying that the virus is weaker because there's not as many people dying. Well, but then you're forgetting the bottom line is that we only have 1,300 ICU beds in the entire state. So even though less people are dying and getting a severe disease, you don't have as many ICU beds to treat them anyway because the numbers keep going up. So this is a very important point to make, is that it's all about the bottom line. Right now at our healthcare system, which we have 6 hospitals in the system, most of them, with the exception of one hospital, is beyond ICU capacity. Meaning that if I have someone who needs a ventilator or needs to be on some form of critical care monitoring, then I have to put them in a regular room elsewhere in the hospital and try to offer them as much care as I could if they were in the ICU. And keep in mind is that there are patients who need the ICU that don't have COVID and they have other conditions, because medicine doesn't stop and just open up everything to COVID. You still have patients who have sicknesses from other problems. So there's certainly not enough of a capacity to treat everyone. And that's important to keep in mind. So what is the risk of COVID-19 in those that are hospitalized? So if someone goes into the hospital, they have an 80% survival chance and a 20% death chance. So even though I showed before that the death rate is low like this, but if someone needs to go to the hospital, then that death rate already shot up. And so then the question becomes are you a gambler for the person who just is not afraid of COVID, and would you play Russian roulette and just gamble with your life? Is it worth it? So that's the question that I offer. So let's give a positive perspective on things. So my hope is that once this vaccine comes out, then we'll start to have a better handle on COVID-19. And we do have hope because one company just published their vaccine called mRNA 1273. I'm sure they'll find a better name once it's approved by FDA. But they tried a phase 1 study and they did 45 adults ages 18 to 55, and they tried different doses, and they found that, okay, well, great, the body was able to mount an immune response against the vaccine. So when you give someone a vaccine, you're giving them part of a virus so that they can develop an immune response against it. So that way, when they get the real virus, they have an immunity to fight it off. So we were able to successfully develop that. So then the next, once you have one phase that works, then you can do another phase 1 study with an older population, 56 to 70, and then another one that's greater than 71. And so they just completed the enrollment, and then we'll see what the analysis shows further on. And then we have another phase 2 study that's enrolled 300 young and 300 older adults. And this week, actually just Monday, they started their phase 3 trial, which is a much larger study. And hopefully if they finish it by October time, then perhaps we'll have a vaccine available by the new year. And this is just to show you that that's not the only vaccine. We actually have 9 companies around the world that are making vaccines. And so we're very excited. So this is, the phase 2 studies right now that have completed. So this vaccine has finished, and then this vaccine has finished, one in the US, one in the UK. And then you have other companies that are developing vaccines as well. So for now, what do we do? Well, we have a face mask that we should use. Why? Because we now know that face masks actually decrease the rate of transmission. Well, then how can you show me this in a picture? Well, if you have someone sneeze or cough at a petri dish, and you can see how having no mask versus having a mask and how much you can transmit. So clearly wearing a mask decreases the rate of transmission, whether it's a sneeze, a song, talking, or 2 coughs, okay? Social distancing. Why social distancing? Because studies have shown actually that at 200 centimeters, so at 6 feet, that you're pretty much done spraying what you have to say. And so whether it's heavy droplets that fall down immediately or smaller particles that are still in the air, so our spit usually ends before 6 feet. So that's the other reason for the social distancing. And then the third thing that we should do is hand washing. So why hand washing? Because it turns out we touch our face about 23 times an hour without realizing. So you can easily touch a surface, have the virus on your hands, and then you're touching your face 23 times an hour. So you're going to spread the virus all over. So washing our hands constantly, social distancing, and face masks will help prevent the spread of the virus until we're able to find another solution. All right, so what about MS now in the world of COVID? So we had some burning questions ever since COVID happened. The first one was, does having MS increase susceptibility to an infection with COVID? So the answer is no, because MS is a disease where the it's not an immune deficiency disease, it's an immune activity. So the immune system is already active, and so it's not that MS is going to make you susceptible to getting the virus. And actually data from our studies have shown that MS patients really we've not seen a greater risk of MS infections than in the general population. So does being on disease-modifying therapy for MS increase the risk of having COVID? So that was one of our fears with the certain DMTs that we have, disease-modifying therapy. So our fear was that patients on certain medications, they may be at risk to develop COVID because the medications suppress the immune system. I'll give you the ultimate answer, and the answer to this is not so much, and I'll show you the data on why that is. All right, what are the best choices for starting a disease-modifying therapy during the pandemic? So that answer also changed as we went from March to April to May to June to July now. And the answer is going to be is that the best choice in this pandemic is the choice that's based on your MS and your lifestyle and what we can offer you or give you at that moment. And so let the MS decide what medication you should be on and not the COVID-19. And then, are changes necessary to the dosing of current disease-modifying therapy during the pandemic? Yes, in certain cases, more so if someone has an active infection with COVID-19, but it really depends on the medication that the patient is on. So the first data that we got was a registry done in France. So that's the COVISEP registry. So they looked at, they published 347 MS patients who've had MS for about 13 years. And it's kind of spread the way that we typically would expect people to have: relapsing, remitting, secondary progressive, primary progressive. And they had a low disability score. So and the use of the medication. So these are some of the disease modifying therapies for MS, and it was spread out sort of evenly with what we would expect to see in any practice in the world. So, in terms of the rating of how severe it is, and so this is 1 meaning not hospitalized at all and not having any problems, 2, still not hospitalized but having some limitation of activity, 3, that's hospitalized but then they don't need much support, 4 is hospitalized and they need oxygen, 5, now they're starting to, 5 is now they're hospitalized and they need some sort of ventilation to get air into their lungs. 6 is they need a ventilator, and then 7 is death. So clearly you can see now the colors are almost equal in all of these boxes, meaning that it doesn't matter which drug the patient was on, that their risk was almost about the same in these categories. The other thing to keep in mind is that look at the gray, which is the no treatment. So there was a decent number of patients that had no treatment in all of these boxes. So really, someone who's on treatment and someone who's not on treatment, they still ended up in the same category. The one thing to note here also is that the category 7, the death, is that the largest box was the no treatment box. So that may be something worth thinking about. So now, what about the outcomes when you look at the DMT itself? And so this is interferon, Copaxone, Aubagio, Tecfidera, Tesabri, Gilenya, Ocrevus, rituximab, which we use sometimes in MS, Mavenclad, Lemtrada, and others. So then you look at the severity per the medication. And again, the lighter colors are the 1 and 2. And so most of the drugs had 1 and 2. And the people that were on no treatment had the darkest box, which is the severe, the 6 to 7. So the bottom line here is that really the disease-modifying therapy doesn't seem to play a role in the risk of developing a severe COVID infection. Now, in looking at, okay, well, what about the risk factors for COVID-19 in these MS patients? And if you look here, so anything on this side, on the right-hand side of the line, it means that it's a higher risk of a severe outcome. Anything on this side is a lower risk of severe outcome. So you can see here, so age certainly plays a role. Being a male, I guess, plays a role. Having other comorbidities, so like other medical problems like hypertension, obesity, etc. A cardiac disease certainly is there, one of the highest. And then lung disease, pulmonary disease, diabetes is there. And then you have obesity, and then a progressive course. The progressive course of MS, it may be so because if a patient is is not able to move as much, then they're not able to open up their lungs as much and move it. So it's more related to the physical aspect of the mechanics of breathing. And then you look at the lower risk, and so interferon, and then some of the MS medications, and then the other ones. So why is it that disease-modifying therapies in MS may put people at lower risk for a severe outcome? Well, because if COVID-19 is an immune reaction in the lungs, then perhaps medications that suppress the immune system are able to also help that disease that's in the lungs. So now what about the United States? So we have this registry through the National MS Society, CMSC, and then the MS Society of Canada. It's called COVIMS. And this registry is ongoing. So every practice in the United States will just enter in data from their own patients, those that we know that have had COVID. So our staff has put into this registry some of our patients that we know that have developed COVID. So, so far in the registry, and this is ongoing. So from the last time that I extracted this data, it's 575 patients that have had COVID. And then 18 have NMO, and then 575 have MS. Some of them have other categories of immune diseases. They show you that about 60% recovered, and then there's a 6% death, and then some people didn't develop symptoms. In terms of the disease-modifying therapy, between the deceased, those that died and those that lived, there really isn't a big flag here or indication that a certain disease-modifying therapy was a risk. The only thing here is you see the category below which says none. So you can see here the highest number where the deceased 60% versus the alive 18%. There's one thing that I should point out also here is that those that are not necessarily on disease-modifying therapy, they sometimes tend to be the older patients that no longer need to be, like they've had MS for a long period of time and they no longer need to be on disease-modifying therapy. So there may be a co-founding factor in that it's not because they're not on therapy, but it's just that they're transitioned into a different phase where they're at risk for COVID anyway. So that's why it looks the way that it looks right now. And then looking at the risk factors, and so cardiovascular disease again shows up here as a risk factor with 17% that have died. And then diabetes, about 14%, hypertension, 33%, and then obesity. So it's the same risk factors that we saw in the French registry in the United States registry. So that seems to play a bigger role than the MS and the MS disease-modifying therapies do. So this is just, I'm basically just trying to show that, you know, depending on the medication that someone is on, and so we theorize how the medication works and whether it plays a role in the risk of developing infections. And then what would you do, how would it play a role in COVID-19? Like, for example, interferon, decreasing the inflammation that's in there. And then predicted potential to increase the risk of COVID. See, most of them are none, probably low. So we really don't think that disease-modifying therapy will make COVID worse. And this is my final slide just to show you that there is a global data sharing initiative that has been put forth where we can have registries where it's clinician reported and then registries that are patient reported, and then to try to put this all together in a database so that we can learn more about COVID-19 and learn about what our MS patients are going through. So this is ongoing, and we have hope as we are moving along this pandemic. And I'll stop right there and leave it open for questions. So thank you, everyone.
For those of you who do have questions or comments for Dr. Subei, use the raise hand feature in the app or send your question via chat. To raise your hand, click the screen to pull up the menu and select more, which is the icon with 3 dots, and click raise hand. For those of you on computers, you'll find the raise hand feature in the participants window. I'll unmute you and you'll see a pop-up on the screen asking if you want to be unmuted, and you'd select allow so you can speak to Dr. Subei directly. But in our chat box, we have a question from Rachel Phillips. She says, my neurologist recommends that I don't take pneumonia or flu vaccine due to my MS. And would you recommend taking the COVID-19 vaccine when it's released?
All right, so I'm going to start with just a disclaimer saying that I can't answer specific questions related to a person or a situation, but I will give answers in general. So in general, vaccinations in MS depends on the patient's disease modifying therapy. So if someone has MS and they're not on medication, then there should not be a contraindication to being vaccinated. Certain disease modifying therapies will require an adjustment or some kind of a change when it comes to vaccinations. And certain vaccines may require disease modifying therapies to be stopped or it may not. So it all depends. That specific situation should be discussed with your physician.
We have a question sent to us by email from a guy named Richard. He asks, is it possible that the overactive immune system in a person not on medication could provide protection against the virus?
So we don't know the answer to that because this sort of thing is very hard to study. It's already taken us this long to learn about what typical patients go through with COVID and how they recover from it. Mm-hmm. And so to try to collect data on MS patients that are not on disease modifying therapies and trying to see, that's a bit complicated. What would be interesting down the road, and this also needs time, is if you have a study that looks at MS patients who are not on disease modifying therapies that happen to develop COVID and looking at their age, their risk factors, and their histories in terms of what other elements played a role. But that's going to be down the line, not anytime soon.
Another question we received from Debbie by email. She asks, does taking dimethyl fumarate alone further increase the degree of the severity of symptoms in already high-risk patients, for example, those over 60 with hypertension, heart disease, diabetes?
Based on the data that I've shown and what I know is that dimethyl fumarate, which is Tecfidera, does not increase the risk of the severity of COVID.
It looks like there aren't any more questions coming in the chat, and I don't see any hand raises. Did you have any final thoughts, anything to add?
I know that our patients have a lot of anxiety surrounding this pandemic and what to do and all that. I just would just say that, you know, have faith, try to do as much as you can to protect yourself, and have a discussion one-on-one with your neurologist about, you know, what do you think, am I doing the right thing? What do you think I should do? And what's the plan of action? And just have a good conversation with your neurologist.
All right. Oh, Valerie, thank you. She asks, so it's okay to have the flu shot?
The flu shot is an inactive virus. And so in most situations, it's okay to take the flu shot. I can't answer specific questions.
With that being said, that's all the time we have for today. If you missed any part of this conference, it will be available on demand on our MS Focus SoundCloud page, msfocusradio.org, and on the Multiple Sclerosis Foundation YouTube channel. And be sure to follow MS Focus on Facebook, Twitter, and Instagram for times and access information. And our next Zoom conference will be next Wednesday, August 5th at 3 p.m. Eastern Time with Michael D. Wild, whose topic is estate planning and asset protection for those with special needs. And our sincere thanks to all attendees for your participation. And we'd like to thank you, Dr. Subei. Thank you so much for the
Thank you
time
so
you
much.
spent to prepare and share this information with us.
My pleasure. Thank you so much.